be talking about a case today, a 53-year-old Bengali male, presented with left-sided non-radiating chest pain. He described as a squeezing sensation for 4 hours, progressively worsening to about 8 out of 10. Started after waking up from sleep. Had similar symptoms in the past. Had an NSTEMI in April of last year. Came into our facility and had a drug-eluting stent. Promus Premier placed in the proximal RCA 3538, and cutting balloon performed to the distal RCA. Has a history of hypertension, dyslipidemia, and is a Plavix non-responder. So interestingly, he was on DAPT for a year, and in April of this year, his second antiplatelet agent, Effiant, was DC'd by his outpatient cardiologist. Patient is a former smoker, quit about a year and a half ago, so he was actually a smoker during the time of his initial infarct. And notably, he's had a decrease in exercise tolerance over the past 2 to 3 months, and actually had a stress MPI, which showed no ischemia in December of last year, and has a preserved EF with minimal valvular dysfunction. So came into our facility. By the time he reached our facility, again, he's been having 4 hours of chest pain. Physical examination was benign, and vitals were stable. Patient's EKG showed normal sinus rhythm. Q waves in the inferior leads with T wave inversions that were actually there on the previous EKG. And his first set of enzymes was about 2 and change, his first troponin. Patient was put on dual antiplatelet therapy, heparin, drip, Lipitor 80, and treated until brought to the cath lab. So he was brought to the cath lab, did a right femoral approach, and we took a shot of the left. You can see that the left side, the left main looks preserved. There's mild disease, but you can already appreciate collateralization going over to the right, best seen in this view here. And you can his LV-gram, as you saw, was normal, and you could appreciate a proximal occlusion of the RCA, in-stent thrombosis present here. So we upgraded from a 6 French. April of the last year.
1 year.
April of 2016. Yeah.
That was a non-STEMI. We should have shown his old angio. He had a distal RCA stent, and that presented with a thrombus. Probably it was a stent thrombosis also at that time.
Mm-hmm.
So we had recommended he should be on a lifelong
DAPT.
DAP. But somehow it was stopped, and 6 weeks as soon as stopped, right?
Yes.
For 6 weeks.
Yes.
So he stopped it up.
That's wild, yeah. Strange.
So
Now you see.
we upgraded to an AL guide,
So
long
much-
sheet obviously,
so much
and
clot.
we went in with a 2015 balloon, non-compliant, and 3020
Did you aspirate?
compliant,
Yeah, yeah.
and we did an aspiration thrombectomy, and this is what we got. So quite impressive results of the aspiration thrombectomy. So we treated the patient for
So the final of the first
yeah, sure. So this is the final result of the first angiogram. You can see distally, you can still appreciate there's still some thrombus
Still
burden
have a lot
there.
of clot.
So we treated the patient for 48 hours with heparin drip, and brought the patient back for a repeat
Did you give
angiogram.
a 2B3A
I
here?
did not give 2B3A. I'm not a believer of 2B3A. But more important, I think that when we did thrombectomy, whatever we were trying to suck, maybe some of it got
Dislodged.
Yeah,
the
well, that's
distal,
what
and you see a
happens.
big, thrombus distal. So
Huge.
it is trying to go from PDA to AV to PDA. We tried to balloon both sides.
Yeah.
So
Somewhat
we left it.
delayed presentation,
Yes.
and with a fairly large right, would you have considered the angiojet and the use of intracoronary vasodilators? Those are the two things I have.
We did give you a lot of the vasodilators.
Mhm.
But this, I think this suction works equally good. We used to do angiojet a lot in the past, and then subsequently realized distal embolization is a lot with that bulky device.
Yeah. Is there? It looks like I can't tell if the mid right coronary is
Yeah.
stented there. I mean, it looks like there's a
There's a
lesion
stent there
There's-
too,
Yeah,
no?
it's a stent.
It's a stent there too.
Thrombus.
It's just
Yeah.
clot all around.
That's all thrombus. So you didn't. How often are
Like
you
you said,
using?
it's all- Another thing I've also noticed
would've
is
given
once it's a
2B3.
stent thrombosis, it does it's the clot, organized clot is different
Yeah,
to your
absolutely.
native. You wire it,
We
good
do
flow.
fine. Yeah, these
no
get pretty
problem.
messy.
This one, you just cannot get a good result.
How often are you IVUSing these stent thromboses? We're using a lot of IVUS for stent thrombosis, at least the first presentation, because
definitely.
those patients come in referred, and oftentimes they have underdeployment. I mean, this is
You
obviously
just don't
patients
know
that,
if this
yeah.
was under, I can't
Understanding.
understand why this happened. Honestly, it's very rare, you know, this kind
Yeah,
of,
poor guy.
especially with such a huge presentation.
I think one of the
We
important
have,
points is if you're going to do aspiration, you've got to do it. You can't just pass it once and say, oh, I got it out.
Right.
No, you have to keep going and keep going and keep going.
Absolutely, yeah, we went multiple
did actually.
times.
Yeah,
We went
that's what
multiple
they
times.
basically are saying.
Yeah.
Oh, we got so
We
much
went
of
3
problems.
times, yeah.
Yeah.
But that interesting question of the same, should we have imaged with IVUS? We have a couple of other cases with OCT,
Okay,
Yeah.
understanding what actually happened in these
Yeah.
cases.
Yes. So we treated the patient with heparin for 48 hours and brought the patient back for a repeat. Again, this is what we aspirated out after three pulls.
It's kind of like the live
and
case
we
at-
brought the
in
patient
Houston.
back for a repeat angiography 2 days later. But you
That's
could
great.
still appreciate there is some thrombus distally, especially you can see it here in this area.
But the mid one is.
So in the meantime, you're
Yeah.
giving ticagrelor
Yeah.
and,
Correct.
you know,
Patients
potent
on Efian
agents.
and
So the
aspirin.
caution of the
Uh,
same should be
Efian.
given him 2B3 infusion, 48 hours, the old time treatment. But
Or intracoronary. I might have given intracoronary if his risk of bleeding is not so.
Yeah, I think the disappointing thing, there's not much blushing, right?
There's
So
no-
I think
right.
the vasculature is still clogged.
It's still clogged up.
So the discussion points. This case brings us to defining stent thrombosis, optimal length of treatment with dual antiplatelets, and it's very befitting after Dr. Rao's talk, especially with bleeding. We have to balance extending the dual antiplatelets for as long as we can, but also balance the bleeding aspect of it. And then, is there a way to stratify the patients who would benefit from long-term Dapton? When we talk about stent thrombosis, we talk about definite, probable, and possible. Definite is proved angiographically. Probable is unexplained death within a month, or a patient having an MI in the territory that the stent was placed. And possible is they die after a month after the stent was placed. And the time frame when we talk about stent thrombosis based on the ARC is there's acute, subacute, late, and very late. So early, which is split up into acute and subacute, is less than a month. Late, 1 month to 1 year, and then very late is a year after the stent was placed. So there's multiple trials with regards to extending the dual antiplatelet therapy for as long as you can. The DAP trial specifically looked at 30 months, and you can see the other trials here, which look at endpoints with dual antiplatelet therapy. So is there benefit of going beyond a year? Clearly, there's a lessened stent thrombosis burden and lower MACE with extending the DAP beyond a year, but that also comes with the risk of bleeding associated with extending the DAP beyond that year. I saw that your talk really went into Ye's paper on DAP study risk stratification. So can we look at particular patients and decide based on their history whether or not they should be on DAP long term? There's a score based on the DAP study, and 2 is the cutoff, and it looks at these different points with regards to whether or not to go beyond a year. And in the high-risk patients, 2 or more, the patients had a lower MI and stent thrombosis, though they did have more bleeding. That was statistically significant. So again, greater than or equal to 2 is the cutoff, and we can use this to help us, especially when we define the anatomy and then we follow up the patients in our practice. And so let's tie it all back into the patient that we took care of. So if we use the DAP study, which is actually available on the ACC website as a risk calculator, and we calculate his specific score, his score was 3. It really nicely gives you the risk associated with if DAP discontinued versus discontinued, and it also gives you the change in risk involved with continuing DAP beyond a year. And for 2 or more, in this particular patient who really has no renal insufficiency and no history of a GI bleed, which is a patient who is at relatively low risk of bleeding, he would likely benefit from more than a year of DAPT. And so Dangus and others actually looked at is there a way to differentiate or predict, aside from dual antiplatelet therapy, are there other factors involved which can help us decide whether or not someone will have a stent thrombosis early versus late. And so there are other factors involved. For example, if someone has a STEMI or is currently smoking, then they would be at higher risk of having a stent thrombosis late. And there's, aside from the DAP study, there's also the PARA study. And the PARA study also can help you decide whether or not the patient should be on long-term DAP, and also really helps you decide on whether or not the patient is at bleeding risk. So you can really balance the two. And you can really look at their bleeding risk score to decide if they're at high risk or intermediate risk or low risk, and then decide on whether or not they would benefit from the second antiplatelet agent long term. So based on the ACC/AHA guideline focus update, moderately strong evidence that prolonged DAPT after implantation of the newer generation drug-eluting stents. There's a balance there between the risk of thrombosis MI and the increased risk of major hemorrhage. And really, in the end of the day, there's no cookie-cutter answer. You have to specifically look at your patient, look at his history, and decide. After you've defined the anatomy, then the hard part comes in. The more difficult part of taking care of the patient is deciding whether or not they should be on the second antiplatelet. And it's a nice topic, and it's really a difficult topic to dive into. But we have an amazing group of people here who are all so involved in making these decisions. So I'm really humbled to be able to open up the discussion about this. Thank you.
So what do you think of that case? I'm, obviously, the patients, what do you think, Sunil? I mean, I don't know why that happened. I don't know that we should be guided with a case like that to say now we should be prolonging dual antiplatelet therapy on patients, but what do you think happened there?
So, it's hard to say. I mean, I think that this patient obviously stopped dual antiplatelet therapy in a way after 1 year, even though he was counseled to take it for a long time. And I think that underscores the challenge of what we tell patients and what they hear, what they want to do. The other challenge I think that we run into, and I'm sure you all run into this as a referral center, is that we're very fond of blaming patients for stent thrombosis.
I know.
But I'm sure you get patients who have stents on the outside, and you look at it and you say, geez, is that really the final result that you were happy with? So I guess for the trainees in the room, I would just say that what you're learning here about optimal stent implantation is something that you should definitely take with you when you go into practice. I mean, you saw today, the case this morning, very, very complex case, made it look easy, but that's because they have so much experience, and it's just important to take your time and get the best result you can, even if it's 6 o'clock at night or 8. I mean, you run the lab until midnight here, so if
Tonight will be one of those.
11:30 p.m. and you want to get home, you got to make sure that you get the right result. That's important.
Dave, what do you think happened in that case?
It's speculative. The left side looked relatively clean, as you note. But one of the things I worry about is with this extent of disease in the right coronary, whether or not this is one of the unique cases where there's an extent of neoatherosclerosis. There's such a large thrombus burden in there. I wonder if there was actually a long area of restenosis that allowed slow flow. The best antiplatelet, we say, is flow, right? Radius to the 4th power. And I just wonder if there was enough stagnation in that vessel that actually thrombosis had occurred, as opposed to, say, some uncovered struts that just happened to spark thrombus formation. I suspect there was some slow flow in there.
I think we need your engineer son to answer that question.
I think the first shot of the left coronary system didn't show much collaterals either, which gave me some concern.
Yeah, that's true.
Excellent point.
So now what is the strategy now? Continue lifelong?
Continue lifelong.
I think for this patient, but what's the bleeding score of this? We didn't talk about the precise DAPT score, which I think is a really nice bleeding score. That did you calculate the precise DAPT, and what was the Paris score too? It's just nice. You have the DAPT score. What was it?
The DAP score.
This is the DAP score.
Yeah, this is the DAP score came out to 3.
Right. What was the
and the-
did you do a precise DAP score? Do you know that?
I didn't do a precise DAP score, which is a third.
Yeah, because
it's a
that's a
third
really
algorithm you
nice
can go
one
down.
for bleeding. One of the things that's missing here on the bleeding side of the DAPT is what already was mentioned. One, you have to be free. For this patient, it would have been great because
'cause he's
it was a
already on 1
year
year of,
and.
DAPT, yeah.
But there is no oral anticoagulants in there, and and CKD kind of got, there is this to me it's like a NACE score, the DAPT score, whereas these other scores do give you the bleeding and the thrombotic risk, and you plot it and you figure out what's going on. The precise DAPT I actually really like because I think it has a really good bleeding. It was from 2 huge randomized studies. And I wonder if we have to use that score at the time of PCI, even though it's not Paris, that score at the time of PCI to really kind of figure out what kind of a strategy we're going to do for the prolonged dual antiplatelet therapies. I know that there is a master DAPT trial ongoing right now under the guidance of Marco Balgamigli, and the entry criteria is the use of the DAPT score. His DAPT score, the precise DAPT score, to figure out where they should go and what they should get. And I kind of like that, and I think that's kind of going to be sort of the future of how we do these things.
No, I
isn't
think
it?
it's great to use risk scores to randomize patients. I mean, the
We have to
problem.
design studies like that, though.
To randomize, and while you were polite and kind to say don't blame the patient, one of the frustrations I have is it seems like when we do identify patients
We
and
don't-
we try to affect a change,
Yeah.
It's hard.
it doesn't make a difference, right?
Right,
So when we
right.
do, say the PRU was 254 or something
Right,
like
right.
that.
That didn't make sense. Make a difference, right?
Right, but then you do say, okay, we're
Right.
going to give them more aggressive therapy. It doesn't seem like we're affecting a big change, right?
Yeah,
It seems
yeah.
like we're rather identifying them, right?
Yeah.
It's like the high creatinine, but you're not affecting an
Yeah, the
outcome.
change.
Right,
That's
right.
true.
You're right about that. That's interesting too. All right.
Case.
All
Can we
right.
go to the next one?